Now we move on to case 6. This is a 3-year-old with a renal mass. Here is a lower power view of the tumor. I did not find a good interface with the renal parenchyma, but here you can clearly see on the left hemorrhage and necrosis. So this is going to be a malignant neoplasm, and it has a different look than what we've seen for the adult tumors. Namely, we've got varying components that you can see from low magnification, including these tubule formations or epithelial structures. We've got primitive blue cells over here and also mixed in with the tubules. And separating these components, we have a spindle cell population here. So we'll start first with the primitive small blue cell population, and we'll call that blastema. But again, it's an embryonal or primitive appearance to the tumor cells. Most notably, they have larger nuclei, very little cytoplasm, which gives it that blue appearance from low magnification. Now, we saw the case in an earlier video of a metanephric adenoma, which also had, at least from a low power appearance, a small blue cell appearance. But upon higher magnification, the cells were relatively monotonous and lacked malignant features. Here we have much more nuclear pleomorphism. You can see the nuclear membranes are much more irregular, the chromatin's coarse, and we have a lot of programmed cell death or apoptosis. Here is a view of the epithelial structure that we saw from low magnification, and although it's making this tubular epithelial structure, they still appear to be malignant cells, and the cells are not terribly different from the blastema that we saw earlier, with abundant nuclear debris. And here are the stromal or mesenchymal cells present between the blastema and the epithelial structures. So they have more elongate nuclei and they're growing in more fascicular arrangements. So in conclusion, that triphasic appearance is pretty characteristic of the diagnosis, which is a Wilms tumor. So Wilms tumor, which is also known as a nephroblastoma, is a malignant neoplasm that is derived from nephrogenic blastema cells, in other words, primitive cells, that when they grow, they recapitulate a developing kidney, so you end up with the triphasic appearance. The vast majority occur in children less than 10 years of age, and the mean age is somewhere around 3 years. It is the most common renal tumor in children of that age. They typically present with a palpable abdominal mass, and around 10% are associated with genetic syndromes, and we'll talk a little more about that in a bit. Treatment is radical nephrectomy, chemotherapy, or both. They can metastasize to regional lymph nodes, to the lung, to the liver. Most patients are low stage with favorable histology, and overall the 4-year survival is around 90%. So here is a case. As you can see, it's large, it's hemorrhagic, it has this cystic change, which is probably caused by necrosis. So grossly, they appear as malignant neoplasms. But it's really the histology that gives these tumors away. And similar to the case that we saw, we have a combination of blue cells, which we'll call blastema, tubular structures, which is considered to be epithelial in origin, and then the spindled or mesenchymal background, which is the stroma. Blastema refers to these primitive cells with large nuclei and conspicuous cytoplasm, and consistent with being a malignancy, you'll see a lot of mitoses, you'll see programmed cell death. Here's an example of the tubular structures, which are considered epithelial, and you can see they're even trying to make glomeruli, and then the stromal elements around the tubules. The blastema elements are often closely packed and highly cellular. Again, they have scant cytoplasm. They may form cords and trabeculae, and mitoses are going to be frequent, as you can see here. The epithelial structures can actually vary from simple tubules to more complex tubular arrangements and even mucinous type epithelium. You can see squamous epithelium, you can see papillary structures. The stromal component can also undergo heterologous differentiation, and that means it's forming structures that are not typically found within the kidney. Here's an example where it's forming skeletal muscle or primitive skeletal muscle. But it can also differentiate into smooth muscle. It can have more of a fibroblastic appearance. It can form cartilage, bone, adipose tissue, even neurons. So you are evaluating a Wilms tumor from a 3-year-old child. You identified the characteristic triphasic pattern, but now you need to name an important histologic finding that is associated with a poor outcome. And the answer is anaplasia. This is seen in around 5% of cases, and it does have a definition of nuclear enlargement that is 3 times that of the non-anaplastic nuclei. And very characteristically, you'll find atypical multipolar mitotic figures. If you need help with immunohistochemistry, the anaplastic components generally have strong nuclear expression of p53. So here's an example with anaplasia. You can see a multipolar mitotic figure. You can see some degree of nuclear variability. And a p53 stain was performed, and you have strong upregulation of p53 within the anaplastic cells, suggesting p53 mutations are present. We mentioned in an earlier video where we discussed metanephric adenoma, which also expresses WT1. Wilms tumor expressed WT1 as well, but they co-express WT1 and CD56. While a metanephric adenoma lacks CD56 expression, and it will also lack the triphasic appearance that you see with a Wilms tumor. Also note that the WT1 tends to highlight the blastema and also primitive epithelium, like we saw in this case, but it is generally negative within the more differentiated epithelial structures and within the stromal components. The WT1 gene is often mutated in cases of Wilms tumor, especially if they're associated with genetic syndromes. What is the chromosomal location of the WT1 gene? It's 11p13. This patient, and I'll show you a picture, has a WT1 gene mutation on 11p13 and a documented Wilms tumor, among other problems. What syndrome do you suspect? So the patient here is on the bottom, and the control patient is on the top. So what syndrome do you suspect? It's Wager or Wager syndrome, however you want to say it. WT1 is mutated in Wager syndrome or Wager syndrome, and it's characterized by Wilms tumor, aniridia, which is the picture I showed, GU malformations, and cognitive issues or issues with cognitive development. WT1 is also mutated in Denny's-Drash syndrome, which also has a association with Wilms tumor. They get renal problems with mesangial sclerosis and pseudohermaphroditism. WT1 is less commonly mutated in sporadic cases of Wilms tumor, but you may see deletions in around 30% of cases and point mutations in around 10% of cases. This is the end of the video for case 6.